Webinar, a link for a post-webinar survey will be placed in the chat. We value your feedback and we read all of the feedback that we get, so please complete that survey. And if you're looking for a certificate of attendance, you have to complete that survey. Once you complete it, you will automatically receive the certificate via email. So I want to welcome now our presenter, Matthew Peters. Dr. Peters is an associate professor at Johns Hopkins University School of Medicine. He holds dual appointments in the Department of Psychiatry and Behavioral Sciences and Department of Neurology. He completed his medical school training, psychiatry residency, and neuropsychiatry fellowship at Hopkins before joining the faculty. He is the Director of Clinical Services for Johns Hopkins Bayview Medical Center, as well as the Medical Director of the Johns Hopkins Healthcare Solutions Balance Program, the Telepsychiatry and Telebehavioral Health programs at Hopkins, and Rose Health. An active clinician, teacher, and researcher, Dr. Peters sees patients in the Acquired Brain Injury Clinic and Memory and Alzheimer's Treatment Center at Johns Hopkins Bayview. He has been internationally recognized for his research work and has received research funding from the National Institutes of Health, Department of Defense, and National Alzheimer's Coordinating Center. His research focuses on cognitive and other neuropsychiatric symptoms following traumatic brain injury, with a specific focus on traumatic brain injury in older adults and neuroimaging-based biomarkers. So with that, I am pleased to welcome Dr. Peters.
Hey guys, thanks for having me. I do have some slides I'm going to share, and when I give these types of presentations, I always try to keep in mind the attention span of adult learners and then leave time for questions and answer at the end. So we're going to go through a number of things, but we will have time at the end if anybody does have any questions that come up. The topic that we're going to be discussing today is the complex relationship between suicide and traumatic brain injury. Suicide is a difficult topic to have a conversation about, and I'm going to try to be mindful of that, but there are going to be things that we share and talk about that can be difficult for some people to hear. There won't be any specific patient examples, but we are going to talk through conceptually the topic of suicide and then look through some research that connects suicide to traumatic brain injury, and very much looking forward to sharing some of that information with you guys. I don't have any disclosures that are relevant to this presentation. Just a brief outline. We're going to start with some information, giving a background on suicide, talk about suicidal ideation post-TBI, talk about suicide attempts and completions after TBI, and then I always add a section that focuses in on veterans when we're talking about this topic, given the connection and also given the dedicated research that exists on veterans with a history of traumatic brain injury, and then we'll have some concluding thoughts. Some of these terms like suicidal ideation and suicide attempts, completions, and the meaning of all of that will be part of what we talk about when we go through background information on suicide. So looking at the rates of suicide, they are increasing compared to a general decline in mortality. There was a 36% increase in suicide rates between the year 2000 and 2001. There was a period of time where it looked like suicide rates were going in the other direction between 2019 and 2020 or so. There was actually a decline, and I think people were hopeful that we were on the right path. And then there since then has been, some unfortunate trends in the other direction that the rates do appear to be increasing again. It's one of the 10 leading causes of death overall. And in 2022, which are the most recent CDC estimates, almost 49,500 suicides. And that is still an estimate, but their numbers are usually fairly close once they get all of the data collected. And that is an increase over the 2021 estimates of around, I think, 3% or so. Women are more likely to attempt suicide. Men are more likely to complete. So When we talk about men attempting suicide, they're more likely to use lethal methods than when women attempt suicide. But in any individual case, you're really, when you're doing a suicide risk assessment or you're trying to figure out what happened when someone's tried to harm themselves, you're always weighing the intent of their action as well as the lethality of the action. So, for example, you could have somebody that attempts suicide by overdosing on their psychiatric medications, let's say sertraline or Zoloft, that they really truly think that overdosing on that particular medicine is going to be harmful and is going to result in death. So you got a high intent attempt by doing something like that, but the actual lethality of the attempt is not very high. So that doesn't mean the person's not at risk because the intent was there, but the actual lethality of the attempt was relatively low. We see the opposite sometimes with over-the-counter medications that people, when they overdose on those medicines, they, in their mind, have in the back of their mind that it isn't something that's going to result in death, when in actuality, things like acetaminophen, for example, can be quite dangerous. So we're always trying to do that assessment of what was the intent and what was the lethality of the intent when we're trying to figure out how to help people that do survive after suicide attempts. And veterans are at higher risk than the general population. This probably isn't surprising to anybody that watches the news, but that risk is there. It is greater than the general population, and that still exists through today. So looking at some of the actual CDC data, and I highlight this portion here at the end, as you can see, since the year 2000, there's a consistent increase in age-adjusted rates of suicide. And those numbers climbed significantly, especially between 2006 and 2018. As I mentioned earlier, there was that slight decrease that happened around the year 2019, 2020. But then the most recent estimates show that the trajectory is going in kind of the wrong direction. It's going back up, which isn't what we want to see. When you look at the suicide rates between males and females, and this is talking about completed suicide, you can see that the male rates of completed suicide are higher. Although they make up 50% of the population, they make up around 80% of completed suicides. Looking at this stratified by age, you can see that the risk exists along the age spectrum. But when you look at those individuals 85 years and older, you do see that group remains at increased risk of suicide. It's also a population that tends to be a bit more frail. So some of the attempts, even if perhaps they wouldn't have been as lethal in a younger individual, they are lethal in those folks. They tend to also use more lethal methods. So that could be medications that are more lethal that they happen to be on, or even, getting access to weapons or other things that they can harm themselves. But this has been fairly consistent, that it's across the age range, with some areas or individuals, specifically older adults, and then those in that 20 to 30 age range that are at a slightly increased risk above everybody else. Looking at the method of suicide, firearms, and this is in the United States, firearms are most commonly used when we're talking about completed suicides. Firearms are not the most commonly used when you talk about suicide attempts. It's just that when you use a firearm, the chances of being successful are higher. Suffocation in this case usually means a hanging. And again, these are hard things to talk about, but when you combine using a firearm or suffocation, you end up getting the vast majority of completed suicides. If this were a chart looking at attempted suicides, you'd see a much greater proportion of individuals in that poisoning group. There are a lot of overdose attempts that happen, and in modern medicine, we're able to successfully save that person and they don't end up passing away. So a few definitions that are going to become relevant through the presentation. So suicide-related ideation, this is when you're questioning an individual and they have thoughts of engaging in suicide-related behaviors. This is regardless of the intent or the plan. People can have thoughts about wanting to be dead or wanting to kill themselves. They have different intents, they might have different plans, but when you see the term suicidal ideation or suicide-related ideation, it's really talking about that thought process. Suicide-related communications is similar to the above, but it's when the individual is spontaneously sharing this information. So it could be verbal, it could be nonverbal. We see a lot more of these statements on social media than we really ever have before, or through text messaging to families. So, you know, there are different avenues that people are using to communicate this information. The classical sort of suicide note that people leave behind, that still does happen, but we're seeing technology used more often, things like email and text messages. And I can tell you from going through this with patients, it's a very difficult thing when somebody wakes up, for example, and they have a message like that in their email, that someone that they're thinking about is actually has planned on not being alive the next time they try to reach out. And then suicidal behavior, this can be preparatory, where they're, you know, engaging in acquiring the means of harming themselves, or it could actually be the self-infliction of a potentially injurious behavior. And the idea is that there is evidence of an intent to die. It can be very challenging to tease these things apart when you're sitting there talking to a patient after something has happened. And that's one of the reasons why it takes so much training to be able to safely evaluate somebody's suicide risk and determine whether they need to be admitted or whether they can safely be discharged. Again, speaking from personal clinical experience, it's often takes a lot more time to safely clear somebody to be discharged from the hospital than to say, hey, we're concerned you need to stay for a longer period of time. It can take a lot of collateral and conversations to safely say that somebody can go home after something like this happens. A few final definitions. So warning signs, these are behaviors that a person shows, like buying a gun, or statements that they make, like I'd be better off dead, that suggest a risk of suicide. Risk factors would be the predictors of suicidal behavior, and we're going to go through a few of them. And then protective factors counterbalance that suicide risk. When we're doing these assessments in the clinical setting, you're typically looking at what are the static factors that the person has. So things like age, for example, if they're in that higher age bracket, they're at a higher chance of something like completed suicide, versus dynamic risk factors, which are things that have the potential to change across time. So for example, if somebody has a major depressive disorder that's well treated, at the time that it's well treated, it's going to be less of a risk factor. If they're in an active, decompensated major depressive episode, then that's going to be a risk factor that's relevant right there at that period of time. And then, as I said, protective factors counterbalance risks. That could be protective factors in their life. It could be teams that they have a relationship with, etc. So some risk factors for suicide, not meant to be a complete list, but these are some of the most common ones we think about. It's often said that the two biggest risk factors for suicide, one is previous attempts, and then the other is actually having access to lethal means. We always collect information when we're doing a suicide risk assessment on family history, alcohol and substance abuse, previous psychiatric diagnoses like major depressive disorder, for example, other comorbid health problems that the person might have, difficulties with impulsivity and poor self-control. So when we're talking about our population that has a traumatic brain injury, some of that comes into play. recent losses, so financial, physical, or personal. Again, in the setting of something like a traumatic brain injury, where your role in life or the things that you're able to do may have changed, there certainly are those life changes or losses that can occur. And then a sense of hopelessness. So, these are things that we screen on when we're trying to do the risk assessment. And then protective factors, again, not a complete list, having a sense of responsibility to family, spirituality gets listed, especially if, for example, you follow a religion where suicide is such that you don't make it into heaven, for example. Those individuals, that can be a protective factor. Life satisfaction and how happy you are with where you are in life certainly can be protective. Having children in the home is a protective factor. And then having positive social support or a positive therapeutic relationship. Really, that having somebody, whether it's people in your life or somebody that you established a relationship with in the clinical setting, can be protective. Now, from here on out, we're going to start transitioning to primarily focus on suicide as it relates to traumatic brain injury. I just wanted to get us all on the same page about some of those definitions. So some shared risk factors between suicide and traumatic brain injury. One is age. Another is being of the male sex. Both of those things tend to be associated with traumatic brain injury. Interestingly, if you look at the rates of TBI, some of the things that, like, for example, older adults are at an increased risk of head injury, and older adults are also at an increased risk of suicide. But when you look at males versus females, as you get older, you're more likely to have females that start having more of the head injury, some of that being that they're living for a longer period of time. But some of the risk factors are a little bit different in that sense. But in general, these are the risks that we know are associated with both. Psychiatric disorders associated with both, aggressive behavior associated with both. And as I mentioned earlier, sustaining a traumatic brain injury can lead to changes in roles and impairment of problem-solving strategies. So, we really try not to underestimate the changes in life that having something like a traumatic brain injury can lead to. And it can be a major change from where the person was before that happened. So again, we're going to focus now entirely on suicide as it relates to traumatic brain injury. And we're going to start by talking about suicidal ideation. So these are those, when you're asking somebody those reports that they've considered suicide or they're thinking about it currently. So that's where we're going to start, and then we'll move into actual attempts and completions after that. So there was a really nice research study done that was part of a clinical trial. It was at Harborview Medical Center in Seattle, Washington. And they had 559 adult patients that were admitted with either complicated, mild, moderate, or severe TBI. The definition of complicated mild in this case was that clinically it was a presentation of mild traumatic brain injury, but when they obtained imaging, there was positive imaging findings suggestive of intracranial injury, so things like a bleed. These individuals were admitted to a clinical trial, but then at the same time, they were screening and asking about suicidal ideation. And in this sample, 25% of them reported suicidal ideation during one or more assessments over a 1-year period of time. And 22% of them reported it at 3 or more assessments. And this is a rate 7 times higher than in the general population. So you're talking, essentially 1 in 4 individuals that they're following throughout this clinical trial at some point after their injury report suicidal ideation. Now, this is a graphical representation of that, which I'm going to walk us through a little bit because there's a few important points. First of all, if we look at let me bring up a pointer. So if we look at this line down here, this darker gray line, we're looking at post-injury incidents. So incidents being defined as, this didn't exist at the last time point, it now exists at this time point. So it's new. It's a new incidence of suicidal ideation. You see that new incidence is peaking within, the first 2 months, and then it does slowly drop off. But again, those are individuals that are newly reporting suicidal ideation at that time point. So even at a year out, you're having individuals that are reporting suicidal ideation for the first time. Prevalence is looking at that time point, how many individuals total are actively reporting suicidal ideation. So this is going to include incidents as well as those individuals that have reported it previously and are still reporting suicidal ideation. So post-injury incidents, new report at that time point, prevalence, all of the individuals, new or not, that are reporting suicidal ideation at that time point. And then cumulative incidents, this black line. What makes this so important is that it continues to climb through that first year. So cumulative prevalence is going to be the individuals that at any time in the study have reported suicidal ideation, regardless of whether they're reporting it at that 12-month time period. So prevalence is how many people are reporting it at that time period, regardless of whether it's new or not. Cumulative prevalence is if you look at everybody across the clinical trial, and you start adding up, if at any time point people reported suicidal ideation, what number do you get to? So the reason this is important is that it's continuing to climb through that first year. So what that tells us is that this prevalence rate, even though it looks fairly steady, it's different people. It's different people that are actively experiencing suicidal ideation at that time point. And when you look at, again, reporting it at least once throughout the course of the study, that's where you start getting up to that 25% range. And this is different than other disease states like cancer, for example, where you may be diagnosed with it, you see this spike in suicidal ideation afterwards, but then it starts falling off. You don't have more and more people continuing to report suicidal ideation. There may be some, but it doesn't climb in the same way as it does after head injury. In this study, the strongest predictor of suicidal ideation was the initial depression score. Here they used the Patient Health Questionnaire 8, which removes it's removing the suicide question so that the score you're looking at is not taking that into consideration. And 53% reported some sort of depression at their first assessment. Other predictors of suicidal ideation: prior suicide attempt or psychiatric hospitalization, history of depressive, bipolar, or anxiety disorder, having less than a high school education, and then being on Medicaid insurance. And some of those things are related to psychosocial determinants of health. But you can see kind of the same sort of stuff: the prior attempts, the history of psychiatric illness, all of them are coming into play just like they would in the general population. And 47% of participants that reported suicidal ideation were already receiving mental health treatment at the time of injury, compared to those that don't report suicidal ideation. So you have around half of the people that are reporting this already receiving care or treatment, which the reason that's important is, one, it means that they have that established provider that can help monitor and manage this. But the second is that it highlights the importance as that treating provider of, really commenting or exploring with the person, since your injury, have these symptoms popped up again, or are you experiencing new symptoms? So some takeaways from that section: suicidal ideation was seen in 25% of participants within a year of TBI. And then I already talked about this a little bit, that unlike conditions like cancer, where the risk goes up after the diagnosis and then starts going back down, it appears that the increase after TBI remains elevated through at least the first year. So, we're talking about a change to the brain, and we're talking about a change in how that individual is potentially functioning within society, and it is just a different type of injury or diagnosis than something like cancer, which nobody wants to be diagnosed with that either. But the risk of having those feelings of self-harm presents differently between those types of conditions. And then risk factors for reporting suicide ideation, again, this is important. They're easily collected by the clinical interview if we're asking the right questions as clinicians. Most of this stuff can be picked up on. And then importantly, from this study, how that translates into suicide attempts or completions is not clear. So this is really looking at the thoughts themselves. And the next step that we're going to take is we're going to look at, studies that have actually looked at suicide attempts and completions. So there have been a few really nice large studies that have been done in countries that have national health systems. So this particular study is from the Taiwan National Health Insurance Research Database. It has medical data on more than 99% of residents in Taiwan. And when they looked at the data, there were around 17,500 people with a history of traumatic brain injury. And during a median observation time of around 4 years, those with a history of TBI had a 2.23 time higher risk of attempted suicide. So we're moving past ideation, and now we're actually talking about attempting suicide. And this twofold increase in risk, you're going to keep hearing that seems to be about the number that we land on when we're looking at this data. So an important point is that we're talking about percentages of attempted suicide that are less than 1% of the population or 1% of the individuals being looked at. So the numbers are small, but not by any means insignificant. And the doubling of the rate would be from 0.44 to 0.88. So, when we're talking about actual suicide attempts and later suicide completions, it doesn't really matter what percentage of the population you're talking about. These are individuals that have gotten to a very difficult state of mind, and they're individuals that really, no matter who they are or how many of them happen to attempt, we want to try to take the best care of those individuals as we can and try to minimize those attempts to begin with. Risk factors for suicide attempt following traumatic brain injury. So women at higher rates than men. Again, we're talking about attempts, not completions. So in line with what you see in the general population. There was an increased suicide risk compared to controls across all age groups. So this wasn't just a particular age. These individuals that attempted were more likely to have depression. They were more likely to have an alcohol use disorder, and the attempts were more likely when you looked at increased TBI severity. So this is looking across the follow-up of 15 years. These types of national studies are things that we just can't come anywhere close to some of the follow-up rates or numbers here in the United States. It really takes these national registries. But you're seeing, over a 15-year time period, the proportion of suicide attempts in those with TBI, which is the solid line, just sort of continues to climb and outpace that in the general population. There's probably a leveling off that's happening, further out here. But nonetheless, you can see that gap between those with and without TBI remains the entire time. Now, looking at a second database, and now we're going to look at completed suicide. So that was looking at attempts. This is looking at completed suicide, and it's in the Danish National Patient Registry. Again, a place that has a large national health insurance and a registry that goes along with that. And this particular study looked at data from 1977 to 2014, over 7 million individuals included in the study, and over 500,000 individuals with a medical contact for TBI. So by no means small numbers, quite large numbers. And looking at the individuals that died by suicide during that time, 10% of them had a medical contact for TBI. Now, granted, this is large national data, but we do have a bit of information on what does it mean to have that medical contact. For example, they collect information on, was it a mild injury, a severe injury, was it a skull fracture without documented TBI? So whether mild or severe or skull fracture, you know, there was a risk identified in all three of those buckets. The mild TBI number is larger, but it's also, there's going to be a larger number of people in the database that have a mild TBI compared to those that have a severe TBI. And I can't remember in the paper if they actually looked at what percentage of those with mild TBI or what percentage of those with severe TBI did this represent, but I didn't write it down here. So increased risk was associated with closer temporal proximity to the TBI. So the more like, or the closer to the injury they were, the more likely they were to have a completed suicide. Having more medical contacts for TBI, and we're going to look at that chart, that graph in a minute. Increasing number of days in treatment for TBI, and we'll talk about what that might mean. Severe TBI was a higher risk than mild TBI. So again, when you're talking about percentages, even though it's overall a smaller raw number, that's a smaller number of people with severe TBI in the population to begin with. And there was a higher risk in individuals that had a psychological illness either before or after the head injury. So taking a look at completed suicides with time since traumatic brain injury. So you see the highest incident ratio is happening within 6 months of the injury. But you, again, just like sort of with the ideation, you see this lingering risk that when you're comparing to a control population, even out to 7 years, these individuals are at a higher risk of attempted suicide, even though that has dropped down from the peak that it reaches within 6 months of the injury. Now, number of distinct medical contacts for TBI, the assumption that is being made here is that these are distinct TBI events, meaning that these are individuals that have had either no head injury, one diagnosed head injury, two diagnosed head injuries at different time points, or three diagnosed head injuries at different time points. From their database, you can't say that for certain. These theoretically could be people that are coming back in and having contact for the same injury, but the thought is that if you've had more than one traumatic brain injury, you do see this increased risk that when you get to three or more, and they did look at this by looking at 3, 4, 5, 6 separately, it does start plateauing out after 3 or more injuries, but you see this slight increase that's happening from 1 injury to 2 to 3. And then number of days in treatment for TBI. So for me, the big takeaway here is if you have a medical contact for traumatic brain injury and essentially, less than 1 day. So I would consider this to be something like you come into the emergency room, you've had a head strike, they diagnose you with a head injury, and you're able to go home. There's no need for hospitalization. There's no need for staying overnight. So, this is not a lower risk. You can see that the error bars spread across 1, which means that it's just not different than the baseline incidence of no head injury. But if you're somebody that's coming in and you look well enough to come in, be cleared, go home, it looks like your risk of completed suicide is about that of the general population. As soon as you need 1 day or more, so think of these people as an extended stay in the emergency room to be cleared or an admission to the hospital, as soon as the head injury is significant enough that you need additional medical care beyond just screen in the ED and go home and follow up with your outpatient provider, you start having this elevated risk, and it lingers even if it's just 1 day of treatment. So very notable when we're thinking about who's at risk, that anybody that needs that additional monitoring, it looks like from this national database, there's an increased risk. And then last thing from this particular study, this is looking at no head injury versus an injury that involved a fracture, but not of the skull or the spine. Let's say it's a broken ankle or broken leg bone. And then looking at TBI out here at the end. And as is kind of commonplace in traumatic brain injury research, you're basically here looking at, is it the experience of having a physical trauma or a broken bone or the inflammatory processes that start after the body undergoes trauma that's driving this, or is it something about it specifically being an injury to the brain? And what you see is that really the risk goes way up when we're talking about an injury to the brain versus some other type of fracture or injury that a person may have experienced. So one of the last studies in the general population, before we move into a conversation about veterans, there was a large meta-analysis that was done that looked at a collection of studies analyzing suicide risk following, and this is specifically mild traumatic brain injury. And this is probably the literature that gets the most attention, because mild traumatic brain injuries or concussions are by far the most common experiences that people have. So when this type of literature comes out and there's any evidence of risk, it gets a lot of people's attention. So in this meta-analysis, where you take a number of studies that have been published, you take a look at the data, and then you combine it. And I'm going to show you what that looks like. They had 10 cohort studies, 5 cross-sectional studies, and 2 case control studies. No need in this presentation to explain the differences between those, but just note that by combining all of these things together, you start getting to a larger sample that you can actually look at risk, as opposed to looking at one of these studies in isolation. And in those experience a mild TBI or concussion, you get a 2-fold higher risk of suicide. This was completed suicide, this was suicide attempt, suicidal ideation. So the higher risk is for all 3, which is not entirely surprising, because suicidal ideation tends to drive suicide attempts, and it takes an attempt to have a completion. But you're still getting back to that kind of 2-fold elevated risk, even if it's a mild injury. And this was seen in studies with and without military personnel. And I put this figure up for those of you that have a background in research. This is what the figures look like in meta-analytic studies. And the one that I circled, or I boxed in red here, that is looking at the total relative risk, combining all of the studies together. One would be that the risk is the same as the general population. Anything to the left would mean that you're going towards that no concussion is a greater risk. Anything to the right, you're saying that having a concussion that increases your risk. And fairly universally, except for this one study that crosses that relative risk of 1, which again means equivalent risk regardless of concussion, fairly consistent numbers indicating that around a relative risk of 2, meaning a 2-fold increase in individuals that have had a history of concussion. So a few takeaways from that work, large population-based studies from Taiwan and Denmark showed this increased risk of suicide attempts and completions post-TBI. There were significant risk factors identified: higher TBI severity, a psychological illness before or after the TBI, more medical contacts for TBI, an increasing number of days in treatment for TBI, closer temporal proximity to TBI. So, a number of risk factors that are knowable. You can actually find out this information and know when somebody's going to be potentially at a higher risk. And then this meta-analysis confirmed that even in mild TBI or concussion, you see this 2-fold higher suicide risk. So now just taking a few final moments to do a focus on veterans. This has rightfully so been, had gotten quite a lot of media attention, that there's evidence that even a mild TBI increases risk of suicide in veterans. This was a study that looked at almost 200,000 individuals with mild TBI and around 21,000 with moderate to severe TBI. And regardless, veterans with a TBI history, whether it was mild or moderate severe, had a higher prevalence estimate for all psychiatric diagnoses. So this was most pronounced with PTSD. So yeah, a veteran with a TBI had a 60.5% chance of being diagnosed with PTSD versus 15% in individuals without a history of TBI. And honestly, this is partly driven by the fact that things that happen while in the military, like combat exposure that could drive a TBI, are the same things that can drive something like PTSD. And then when you control for age, gender, psychiatric diagnoses, other chronic conditions, veterans with a history of TBI, back to that, number 2, or twice as likely to die by suicide. And in this case, 68% of them used firearms, and moderate to severe TBI was a higher risk for using firearms. This is a population more likely to have firearms. As I showed earlier, the rates of using firearms in the general population is already above 50%, but you start getting higher numbers when you're talking about the military population. And then a separate study that looked at 460 or so thousand veterans. They matched them 1-to-1 with individuals that had TBI and individuals that did not. And they looked at mode of suicide. Mild TBI was the highest risk among those with TBI, so a slightly different finding, that mild TBI did give increased risk, potentially even more so than moderate to severe TBI. TBI was shown to be associated with suicide and unintended death by drug overdose and firearms, and I'm going to show you the graphics for that in a minute. Actually, right here. So if we look at drug overdose, and you have this blue line that represents no head injury, you have this green and red line, red being moderate to severe, green being mild traumatic brain injury, and you see this elevated cumulative incidence over time of death by drug overdose. And if I remember correctly, these are in months, I believe, but I'll have to look that up. That it's 20 months, 40 months, 60 months, but it could be days. I just don't remember. But you see this elevated risk that is there and remains there of drug overdoses. And the reason drug overdoses are so important is that it can be very difficult to know, was this overdose a suicide attempt or was this overdose accidental? And that's again something that when we're seeing people clinically, we're trying to assess and come to a conclusion. And then this is looking at completed suicide post-TBI using firearms. You see that even in the general population without TBI, actually, my apologies, I'm seeing now this is age in years here. So 20-year-olds, 40-year-olds, 60-year-olds, 80-year-olds. So what's important is, the older individuals, it is a higher risk in this population, just like in the general population. And this death by firearms, similar as you get older in age, you start breaking away from the solid blue line, but regardless, you see this, increase even in the population without TBI of completed suicide by firearm as they age. So concerning in the general population, and then also concerning in the population with head injury. So takeaways from those two studies: veterans with a history of TBI, about twice as likely as veterans without to complete suicide. These individuals have higher rates of psychiatric diagnoses, and that's independent of completing suicide. And death by self-inflicted gunshot wound and drug overdose were the most common methods used. And as I hinted at earlier, drug overdose, it often gets listed as unintended death by overdose rather than completed suicide. So it's hard to know when somebody overdoses. Was it accidental? Was it purposeful? There are, and this actually becomes an interesting political issue, because if you lean towards calling these completed suicides, then you're going to see one rate. if you lean towards these being undetended death, you're going to see a different rate. One's going to make overdose and substance use kind of highlighted. The other would make suicide highlighted. Regardless, these are people that have lost their lives, but it is an interesting topic that often, from a political standpoint, gets discussed, and pressure in the setting of that can be put on medical examiners when they're trying to make these decisions. And then compared to the general population, veterans are already at an increased risk of suicide, and traumatic brain injury makes that worse. So a few concluding thoughts, all of which we've already talked about a little bit. TBI and suicide have some common risk factors, substance use being one, psychiatric diagnoses, changes in a person's role. After a traumatic brain injury, suicidal ideation is seen in 25% of individuals, so a fourth of individuals having these thoughts of suicide, and it remains at least a year post TBI, making it a little different than what the rates look like when people are diagnosed with other types of disorders. In both general and military population, TBI appears to double the risk of completed suicide. And these studies really confirm established risk factors, which, again, trying to drive home, many of these are easily accessible when you are doing a clinical interview with a person. So higher TBI severity in general increases risk. Previous or new onset psychiatric diagnoses, including substance abuse, increases risk, and then previous suicide attempts increase risk. Access to firearms is an important consideration, especially in veterans. And I always end by saying these 2 points. One is that suicide is a rare event. It's heartbreaking regardless of that. But because it's a rare event, it makes it that much more difficult to predict. And traumatic brain injury by itself is difficult to accurately diagnose. We're largely, depending on the clinical history that we're obtaining, it's fairly easy to know if someone's had blunt head trauma. They come in and they have, a bruising to the front of their head because they had a fall. But whether that blunt head trauma has translated to an underlying traumatic brain injury is more difficult. So you have a rare event in suicide, making it hard to study. And then you have a diagnosis that's difficult to confirm in traumatic brain injury, making it hard to study. So, in general, it's important to think about those caveats. And then lastly, neuropsychiatrists and behavioral neurologists, such as myself, that get trained in TBI-related cognitive and other neuropsychiatric symptoms are uniquely poised to treat these individuals. Now, that's all fine and good. It's difficult to get access to a specialist that does this kind of work, but it is a specialized population, and it does need individuals that have focused and care about taking care of individuals that have sustained a brain injury. And with that, I will stop and see if you all have any questions. I appreciate your time.
Thank you so much, Dr. Peters. That was very informative and enlightening. We do have a couple of questions. Anybody who wants to add any questions in the Q&A box, you can feel free to do that now, but I'm going to start looking through them here. Sure. Okay, so one question was, do you have any positive tips that you can share? Maybe some proactive things that somebody can do to prevent suicide?
To prevent suicide. Yeah, I mean, I think that the properly letting your established providers know when something like this has happened to you is really the first starting place. So, you can go to an emergency room, you can be evaluated, you can be cleared, but really making sure that whatever provider it is that knows you the best is aware that you've had this injury, and then also that they're aware of any psychiatric diagnoses or suicide attempts. These are things that with, let's say, a primary care provider may be difficult to discuss, but they can only really help if they're well informed. So, part of it is if you have a medical provider, make sure that they know of your risk and kind of be educated on your own risk. If you have a psychiatric diagnosis and then you're having something like a head injury, there is a risk your diagnosis is going to decompensate and get worse. in the setting of that. So that's one thing. Making sure that your family is aware that you've had the injury. It's, people can get quite embarrassed by anything that involves their brain being different or something happening to their brain. But the more open you are with people that care about you that this has happened, the more likely they are to be able to notice if something has changed. So in general, I think we in my profession don't see patients until far later in their course, not because we don't want to, but because they're unfortunately not coming in until things have gotten to a really bad place. So being proactive about your own healthcare is incredibly important. And I realize that even when you do that, depending on the provider, they're not always the best advocate, but you do need to be that advocate for yourself. And then always, if possible, have that care partner that comes with you to appointments or understands the care that you're receiving. We know across many, many studies how protective that can be.
Great. Yeah, thank you very much. Are TBIs that are associated with substance abuse more or less likely to complete a suicide attempt?
Yeah, it's an individual risk. So, both of them are risk factors. So, your brain would immediately go to, it should be a higher risk than somebody without substance abuse or somebody without a TBI. The actual data, when you control for substance use, the individual risk from TBI is still there. So to put it simply, you have a risk associated with substance abuse, you have a risk associated with TBI. They can be additive. That doesn't mean they are in everybody, but yeah, I would be more concerned based on the data. If you have a substance abuse issue and you have a TBI, you're going to be at an even more of a risk than if that substance use wasn't there. It does not appear to be more of a risk than other psychiatric diagnoses. So if you have depression or bipolar disorder or substance use, they're all independent risk factors, and they all are risks above and beyond the TBI by itself. So the answer is yes, and psychiatric diagnoses would fall into that category too.
Okay, great. Another question is, what are possible drug choices for somebody diagnosed with depression that also has a TBI? And then kind of follow up, is ECT effective with that?
Yeah, so the treatments tend to be similar to what we try in the general population. We'll usually try selective serotonin reuptake inhibitors or SSRIs first. When we are making the decisions of what to try in the patients with TBI that we take care of, we are guided by the literature, but it does not guide us very thoroughly. Again, it's a very difficult population to say that you've properly identified individuals with TBI when you're putting them in a study. And some of the work that we've done, even here at Hopkins, you can see good improvement with the treatments that you put people on. It's not necessarily any more or less than you see in the general population. So what I will say is the approach that we typically take when we're starting somebody with a TBI on medicine, we'll do the same algorithms that we use in the general population. So if it's somebody with, let's say, chronic pain in addition to depression, that might make us choose one antidepressant. If it's somebody that had a TBI and now has attentional difficulties, that might make us choose one antidepressant. We tend to start lower with the doses, go up more slowly than in the general population, but we don't stop. So we say start low, go slow, but don't stop, meaning still go to the higher doses if that's what's needed to help the person, but do it a bit more cautiously. There are studies that have been conducted to try to figure out, is there like one right antidepressant? But what I want to remind people is there's not one right antidepressant for the general population either. So, what we think is that the antidepressant that probably would have worked for that person regardless of a TBI would still work. So we still ask things like, have other people in your family been on antidepressants that have worked for them because there is some evidence that it's more likely to work for the person in front of you. So very similar to the general psychiatric care we provide, we do the same thing. We still perform ECT in individuals with traumatic brain injury. Typically, what we'll do is if, let's say they have neuroimaging, they have changes on imaging related to the TBI, we'll try to wait at least 6 months, meaning we'll get a MRI scan. If the findings look chronic, we'll get another one in 6 months. If it's still stable and they haven't changed, the brain hasn't changed, then we will suggest something like ECT if we feel that it's necessary. But we still will do it. You just want to make sure that anything related to the seizure that comes along with ECT is not going to occur in a brain that's still trying to heal. That our view on that might change as our understanding, which is still evolving, of ECT and what it does changes. We might realize that ECT actually helps the brain get rid of the garbage, get rid of the extra stuff and metabolites that's in there. And so maybe that would be good closer to a head injury. But we're still pretty far away from knowing that.
Thank you. I know we have more questions in the chat, but Dr. Peters is a busy man and he gave us a lot of his time today. So if you have any questions that weren't answered, please email me directly and we can try and get some answers to those questions. And we also put in the chat a link to our webinar survey, so please fill that out. And if you're looking for that certificate of attendance, you need to fill that out as well. But I just want to thank you so much, Dr. Peters. I appreciate your time today.
Yep, thank you all. Have a good day.